Hi there, my name is Matthew Leonardi. I'm a surgeon sonologist at McMaster University in Hamilton, Canada. I'm honored to give a talk today, and I'm very thankful to ISUOG for the kind invitation. This talk is a very broad talk and very difficult to get through in a short time. So I consider this a taste test of this particular topic on why ultrasound is an essential tool when planning surgery in gynecology. Here are my disclosures. Here's how I can be contacted, either by email or on social media, which I encourage all of you to engage on. It's wonderful. My guiding principle as a surgeon and sonologist is that surgeons should not be surprised by what they find at surgery, and more importantly, patients should not be surprised to learn of surgical findings when they awake. For me, ultrasound and surgery are not separate tools. They are really, truly synergistic tools that should be utilized in the diagnosis and management of all gynecologic problems. Today's talk will first identify broad principles on why ultrasound is an essential tool when planning surgery. We'll talk about a few specific examples. Here's the taste test. And finally, we will propose an interesting concept that may improve the learning of diagnostic imaging experts and gynecologists in the future. So, why is ultrasound an essential tool when planning gynecological surgery? First of all, it allows us to understand the etiology of what a patient is experiencing. We can provide them with a diagnosis. We can understand the severity of that pathophysiologic process that is occurring and utilize that to inform ourselves as the surgeons and inform patients. This allows for a more comprehensive, targeted, informed consent process, which is what we should be aiming for with each of our patients. Of course, when we're talking about surgery with patients, the severity of disease does impact on the risks of the surgeries that we perform. And so this is really where that targeted informed consent process will differ. We can ensure, to the best of our ability, that we bring along with us the right people to the surgery, whether that means that we bring along those who are advanced gynecologic surgeons or other surgical services such as colorectal surgery or urology. Gynecologists are notoriously poor at estimating the amount of time that they require to perform a surgery. And so we may be able to use ultrasound to help guide us by understanding the severity and how long each element of a procedure may take. Finally, and this is the really essential piece, ultrasound can see through things that we cannot see through with our eyes at surgery. Peritoneum, the uterus, ovaries, these are all opaque tissues for our eyes. But ultrasound can see through them, allowing us to get a glimpse of disease processes that are occurring that we cannot see with our eyes. And so this, for me, is particularly relevant in the realm of endometriosis, and we'll talk about that in a few slides. Finally, ultrasound and imaging in general can guide surgeons to not do surgery when appropriate. Diagnostic hysteroscopy and diagnostic laparoscopy are two commonly utilized surgical procedures, more so in the past than now, but certainly still utilized to this day, that we can try to reduce the utilization of by integrating imaging to understand things and utilize that imaging to then plan an actual operative surgery if necessary. Early pregnancy and pregnancy in general is a place where ultrasound has a huge utilization. But specifically, when somebody approaches a doctor or hospital in an early pregnancy state with a complaint, one of the first questions we ask is there an intrauterine pregnancy? If there's not an intrauterine pregnancy, we can use ultrasound to try to detect an ectopic pregnancy in the fallopian tubes. And if there is, we may consider surgical intervention. And so we want to know, is that ectopic on the right or is it on the left? Is there cardiac activity in this fetus? That will allow us to better risk stratify a patient to determine the best treatment algorithm for them between expectant, medical, and surgical management. How much fluid is in the pelvis? This is another way of asking, is this ectopic pregnancy ruptured? Is that extending out of the pelvis? So is there blood in the Morrison's pouch? And so the understanding of the fluid state allows us to understand the severity of the disease process, which allows us to plan our surgery. Maybe we have to do the surgery very fast. Maybe we have some time until we can get to it. When there's not a tubal ectopic pregnancy, then we want to look for other ectopic pregnancies in non-tubal sites, including interstitial pregnancies, cesarean scar, ovarian, and cervical. Fibroids are a very common problem, and surgery is often utilized to manage them. Essentially, there are two surgical procedures that can be utilized, myomectomy or a hysterectomy. When we're talking about a myomectomy, we want to know how many fibroids are there? What are the individual sizes of those fibroids, and where are they? Myomectomies can be performed via multiple avenues: hysteroscopy, laparoscopy, or laparotomy. And so if we think a little bit about the FIGO classification, which is depicted just here on the right side of the screen, the type 1 and 0 fibroids are more appropriate to attack hysteroscopically, whereas, of course, the subserosal fibroids, you cannot attack hysteroscopically, and you must go through the abdomen, either through laparoscopy or through laparotomy. So maybe the size is what's going to determine the approach of the myomectomy. When we're talking about a hysterectomy, these are some features that we may consider as relevant features: the uterine size, which may be measured in weight or volume, the width of the uterus, the number of fibroids, the individual sizes of fibroids, and again, the location of fibroids. Hysterectomies can be performed in, again, multiple avenues: vaginal, laparoscopic with or without morcellation, or open, laparotomy. If we're trying to actually decide on the mode of our hysterectomy, maybe the number and the individual size of the fibroids doesn't contribute so much to our decision making, because those are going to be encompassed by the overall uterine size. And so, that amount of detail may not be so contributory to our surgical decision making. But certainly the location remains a very relevant feature, as there may be broad ligament fibroids affecting our ability to skeletonize and transect our uterine artery. There may be cervical fibroids affecting our ability to perform a colpotomy. And so ultrasound is key in determining all of these features. Adenomyosis is an enigmatic disease process still, and we're learning more and more about it via ultrasound every day. The Morphologic Uterine Sonographic Assessment Group, MUSA, has done wonderful work in this area and produced incredible articles that really guide people in the assessment using ultrasound. When we're talking about surgery, the first thing we want to do is differentiate adenomyosis from fibroids, because the surgical procedures are very different. We want to know, is adenomyosis focal or diffuse? Because maybe it is possible to perform an adenomyomectomy, although that is still quite a rare procedure to perform. Hysterectomy is often the surgical procedure that is necessary to definitively manage adenomyosis. When we're thinking about controlling somebody's abnormal uterine bleeding, we think about endometrial ablations. But when those patients have adenomyosis, we may want to reconsider that for fear of producing a post-ablation syndrome. Here's a QR code, which if you pull out your phones, your smartphones, and shine your camera at, you will be able to access the MUSA article that the link will take you to. Endometriosis, which is my main passion. We are trying more and more to perform excision of endometriosis when surgery is integrated. And so we have to acknowledge that there are different phenotypes of endometriosis: superficial, which is peritoneal in origin usually; endometriomas, which are, of course, ovarian cysts within the ovarian cortex; deep endometriosis, which can be within the peritoneum or within viscera. You can see on the top image uterosacral ligament endometriosis extending into the perimetrium, and rectal endometriosis in the lower image. Ultimately, endometriosis can lead to a very severe consequence, which is rectouterine pouch obliteration. The IDEA group has, again, produced a wonderful consensus opinion on how to perform and report ultrasound for endometriosis. The goal can be to non-invasively classify patients to allow us to do the right surgical procedure. So we may consider utilizing mapping to identify the various phenotypes of disease: superficial disease versus ovarian disease versus deep disease. We may consider using a surgical staging system adapted for ultrasound, which is the ASRM system, or we may consider using the ultrasound-based endometriosis staging system, which tries to equate ultrasound findings to surgical complexity. Here's a QR code, which you can utilize to access the IDEA consensus opinion. In the past, diagnostic laparoscopy was essential to diagnose endometriosis and understand the severity, which would often be utilized to perform an operative laparoscopy at a second surgery. Now, with ultrasound, we can actually prevent that diagnostic laparoscopy and simply perform an advanced ultrasound to understand the severity of disease and utilize that information to perform the right operative laparoscopy, which may include, again, various surgical services. If urology is involved for bladder or ureteral deep endometriosis, or the necessity of inserting ureteral catheters, we can predict that preoperatively. Of course, gynecologists, the center of endometriosis management, may utilize ultrasound to appreciate the extent of adhesions present, pouch of Douglas obliteration, ovarian adhesions, and that allows us to understand how extensive our normalization of anatomy process will be. Finally, we can bring along colorectal surgery to perform bowel endometriosis surgery, and we can appreciate the size of the lesion, the location of the lesion, all of which contribute to surgical decision-making. Ovarian masses are a huge topic, but essentially ultrasound can help us determine whether we leave it alone, whether we perform an ovarian cystectomy, or whether we take out the ovary and potentially other structures. In the past, often, the ovarian masses were described as either simple or complex. Of course, complex is a very vague term that does not provide much detail. Therefore, tumor markers have been really important to help us risk stratify. The risk of malignancy index, the RMI, was a very popular tool to use and still is in many places. And that would help us determine the nature to a degree, whether something was benign or malignant, and whether a referral to a gynecologist was necessary. Things are fortunately significantly improving thanks to the International Ovarian Tumor Analysis Group, the IOTA group, which has been integrated now into the ORADS classification. Essentially, the IOTA group has put together various publications. The Simple Rules and the Easy Descriptors are two wonderful publications. Simple Rules allow you to get a rough idea of benign versus malignant etiology. The Easy Descriptors specifically allow you to identify the etiology of a select group of ovarian masses. We're now much more advanced with the ADNEX model, which allows us to risk stratify a patient. And this is the ADNEX model from the website. And essentially, the features that you plug in to the model produce a graphic such as this, which gives you the chance of benignity versus malignancy. And it further breaks that down into the various stages of ovarian malignancy. Here you can access the website through this QR code. Finally, intracavitary pathology is a pathology that is quite broad again, with polyps, fibroids, adhesions, Mullerian anomalies, uterine niches, and retained products of conception. We may consider using two-dimensional ultrasound or three-dimensional ultrasound. We may consider utilizing fluid in the form of a sonohysterography. Ultimately, the ultrasound can help us with these individual entities to understand our management decisions, particularly around surgery. So adhesions may be related to a previous surgical procedure, or they may be related to a pregnancy state, retained products of conception. The procedures that need to be performed and the aftercare is different in these. And so understanding the degree of adhesions, the origin of the adhesions can be useful in our surgical planning. For Mullerian anomalies, we must differentiate between various types, and that information can help us plan surgical procedures. In the context of a uterine septum, we can use ultrasound, 3D ultrasound, to understand the length, the thickness, and the width of the septum. And again, there's going to be a degree of severities that are present, and the informed consent process will be individualized based on our ultrasound findings. Uterine niches, which is a very interesting area of research at the moment, can be managed either laparoscopically or hysteroscopically if they are surgically managed. And the residual myometrial thickness is the main metric that is utilized to help us decide which surgical technique is necessary. The final thought that I'll leave you with is this concept that the surgeon, the gynecologic surgeon, should be sending back surgical reports and pathology reports to the diagnostic imaging experts to allow for a two-way communication channel, which will ultimately aim to improve the knowledge of anatomy, of pathophysiology, of diagnostic imaging experts, to improve their ability in future scans to identify the correct etiology, the correct severity level. And so this is not something that is generally happening. And the question is whether doing this would actually lead to improvement. Thank you so much again to all of you who tuned in. I hope this was helpful. And thank you again to ISUOG for the very kind invitation. I'm very honored to be here. Thank you so much. Bye-bye.